I've always supported initiatives like this, and in particular the Red Cross Motherless Baby Home, and I've been doing that for several years. And they wanted at some point to have to have a small clinic cleaned up for them. And I thought, okay, I can do that, because I was actually at the time building across the road. I had a major development going on. I thought, why not? So I sent workers there, and they thought, no, this is really bad. You know what I mean? You're either going to do something good or not at all. The roof is leaking, and I've been supporting them for like 20 years of my life. I saw the building and I thought, okay, why don't we rebuild this and build you a proper clinic for the motherless children? And we could actually open it up to the Makoko neighborhood. So I said, okay, let's build an efficient framework where I can then move away, but have a very efficient back office, so that we're not going to be faced with a situation where we build a clinic that shuts down. So I haven't done two in the course of 2 years. And I thought, why don't I put structure around this? Why don't I set up my own primary health center? And in the 2 years, I was doing so much research. It became, a project that, I felt, okay, Shola, have you actually thought about what you're doing this for? I felt I was doing it for God, but I didn't know who God was going to bring. But I knew that it had to be people that couldn't afford it. The rest is history. Firstly, it's actually faith-driven. Now, when it's faith-driven, you just have to be, I really just have to remain inside of God for God to direct me which way I should. And it's worked so far.
When Miss Shola Bero was thinking about this initiative, she had seen some of those things, having grown up in Makoko areas, and she was also part of the Red Cross, which is an initiative that was similar. So when she talked about this, I saw it as an opportunity, and for us to be able to really extract the type of information that we want, that means that we must have access to data.
We use the eClinic software. I register them, then it goes to the next stage of vitals. After vitals, then you get to see the doctor. The doctor then decides if they need to run a test or not. After the laboratory test, they're going to hold on for their results. The doctor is going to call them back into his office, explain to them the results. The result will determine if drugs will be dispensed to them here or if it's going to be managed by a secondary institution.
So what eClinic does is that it has some preset information in it that allows us to capture the entire value chain of information that we need. And what do I mean by that? The names and addresses of the customers. The eClinic has the capacity to do some medical diagnostic of the patients themselves, and then present the data in a friendly format that allows us to do any type of analytics that we want to do. Say, for example, the initial stage, what we saw that was mostly prevalent was malaria at about 51%. Now we can see very clearly that malaria is dropping. So it's dropped from 51% now to about 43%. So the eClinic allows us to manage a paperless system. So it's like a paperless medical facility.
This is the first model, and what we hope to be doing in the next 5 years is to have about 10 or 15 of this dotted around Lagos, basically again focusing on just communities. And with the eClinic, we're able to actually from one base access what's happening in all our clinics around Lagos, and that's an efficient tool to have.
The software shows us the amount of patients, the amount of diagnoses we make each day. The ones that are more common, it helps us, it has a chart that grows every day. It also shows us the amount of patients we've seen over a period of time. It shows us the drugs that we are dispensing. It shows us the lab results. We can compare their former lab results to their present lab results. So we can look, are we making progress? Are we going back on all those things? So, and we need all this data as well. Because if we are going to, like I said, if we are going towards preventive, all these data are very, very essential so that we'll know, okay, are we targeting the right set of people? Are we targeting the right location? Are we targeting the right timing, because there are some diseases that are prevalent at a certain time of the year. So we can sit down and look at our data and say, okay, who are affected the most? Where is this disease prevalent? When, which time of the year do we have this disease more? So that's our data analysis. That's basically why we need it.
So these 1,500 patients we have in our database, we know them. Not only do we know them, like we really know them, we also do outreach. We pay visits to their homes. We know their names, their addresses, their locations, their diseases, what they're dealing with.
Ọmọ tí láti ibẹ̀ pẹpẹ tó ti bí bóyá ìyá òun jẹ nutrition lóyún ìgbà tó tún wá bí ìyá ẹ̀ náà ò ní kò rí nǹkan pàtó tó ní nutrition oúnjẹ tí nutrition wà ń bẹ̀.
Child nutrition is very important to us. So we also want to be very active in solving malnutrition problems. We're actually working with the only producer of RUTF and ready-to-use therapeutic food in Nigeria, a company called DABS. And they're supplying RUTF to us. And what we're seeing is remarkable results with patients that we're treating along the Lagos Island axis. And I think we're going to see a lot more of that, because we intend to open a nutrition care center, that would provide RUTF and other supplementary food to children that suffer from severe acute malnutrition.
Hospital ń bí báyìí. In fact, ó dàbí ìgbàlẹ̀. Wọ́n ṣe test fún ni wọ́n wá sọ pé she's lacking by nutrition and also affected by infection. Since there, ibi báyìí ló ti fún mi. Ìgbà tó máa kọ́kọ́ fún 2 nylon ló fún. Before kí n tó ní mo fún tán for that day, ó ti jẹ tán. Ìgbà tó dẹ̀ bẹ̀rẹ̀ sí tán fún oúnjẹ 2 sachets a day. Ìgbà tó yá ó di.
We're very happy to be in that space, and I think in terms of ready-to-use therapeutic food, we're probably the only center in the South that's actually using this supplement. It's available in the north, but it's not available in the south. But we've been able to actually get constant supply from this new manufacturer. And so we find if we turn ourselves into a center in the next couple of months, we'll be able to service several communities. We're currently in Lagos Island. We hope to move to Makoko. And I suppose in 1 year, we actually want to see ourselves as the leading child center in terms of nutrition care.
An entity like this that is 100% free also has to think of a way to be able to generate funds. We don't mind generating funds. We don't mind providing services that we get financially compensated for. All we care is that it's not these individuals that are paying. So one of the things we are going to be getting into now is research and consulting. So we're going to have a little research and consulting arm that is going to be fee-based, so that we can provide the knowledge we're learning here. We can start providing the services at a fee for other entities that want to try and do the same, or even to funding organizations. Sometimes organizations want to fund certain initiatives, but they want to know more about the initiatives before they put their money there. We will develop the capacity to be able to provide those services for them, so that we can turn the money around to support our initiatives. So that's the core. That's a very significant sustainability component of what we're trying to do.
We've tested it. It works. primary health care can be free and should be free. And you know something, my model works in a way that I'm saying it's free for the poor, but ultimately, 10 years down the line, it should be free for everybody.
Àwọn kan ṣiṣẹ́ bí tí wá sọ́dọ̀ wa nísàlẹ̀ Èkó wọ́n ti wá ṣàlàyé fún wa pé ìwòsàn ọ̀fẹ́ wà ń bí irú City Hall o.
Mi tí ẹ̀ gbọ́ tó kọ́kọ́ ta ìgbà yìí padà ṣe ń wá náà ọ̀fẹ́ ni wọ́n gba ẹnìtì lọ́wọ́ wa.
Èyí níbo wa ó sọ pé wọ́n gbowó ǹjẹ́ òkú wọlé papọ̀ tí mo gé dídí wípé wọ́n gbowó ìsẹ́ni kódà kò sí gbọ́ ìbò kan pé ẹgbà iṣẹ́.
Government can frown at it now, but I don't even believe primary health care, where we are today, is a matter for the government. It is not. It is a matter for private sector. Government is unable to do it. I'm sorry. It has to be private sector driven now. This is where I believe private sector should lend a bit of help and bring whatever contributions they can bring to bear. It should be primary health care and basic education as well, but primary health care definitely.